Greetings of the day, myself Dr. Dinesh from India. And after such enlightening presentation from our esteemed faculty, now it's time from faculties from the Asian countries to comment upon the presentation and to share their own experience. So first of all, I would like to invite Dr. Achmad Hidayat, who is a general surgeon and a retired air marshal from the Indonesia Air Force. He's also a former general surgeon in Indonesia Air Forces and former chair of Committee on Trauma in Indonesian Surgical Association. He is a senior consultant in Air Force Hospital Halim AFV Jakarta and National Sports Hospital Jakarta. And he is a renowned national faculty for ATLS and ITLS courses. He is chair of Indonesia Pre-Hospital Trauma Care Association and fellow of the International College of Surgeons. I would request Dr. Achmad Hidayat to make comment on the presentation by Professor Mark Anthony de Moya on the need of refixation. Dr. Achmad Hidayat, please.
My name is Achmad Hidayat from Indonesia. Good morning, good afternoon, and good evening for everyone. First of all, thanks for the committee to invite me as a participant in the webinar. And it's a great honor for me, represent of Indonesia as a reactor in this webinar. The topic of this webinar is very interesting. Improvement and innovation is very important for trauma surgeon. We look like Gulliver as a first trauma surgeon and like MacGyver as innovators man, especially in the country with the uneven health facility and resources constraint. And like it's my country in Indonesia, almost health facility concentrate in big city and island of Java. Well, the committee has asked me as a rector for Professor Mark Moya about fracture or fixation of rib fracture. This task is very difficult for me because the speaker has delivered very clearly. Watching the presentation delivered in 30 minutes, look like I have finished read his book over the 200 pages book, Fracture Management. It has been explained about rib fracture from A to Z. For example, indication for surgery, comparison the result of surgery compared with the non-operative surgery. And it said that no one technique superior with another techniques. And it's very important to be noted. Let me share about rib fracture management in Indonesia. Since last 10 to 16 years, the number of operations for rib fracture in Indonesia has increased, especially in hospital with the trauma surgeon available. However, the number of trauma surgeons in Indonesia is limited, and that's why the general surgeons take part for the manage trauma, thoracic trauma, especially rib fracture. General surgeon do fix for simple cases, carried out in hospital without the trauma surgeon. Besides that, in our country, some friend in Surabaya has innovator clip. The name of clip is Sharp. Short is Setiono, H. Heru, A. Agung, P. Purhito, and Paul Talele. Their design clip is more simple and more cheaper, and that's why many general surgeons do clipping for rib fractures. As general surgeon, sometimes we do fix the fracture, especially in flat chest, and especially for lateral rib fracture. Also, if rib fracture causes the pain when breathing, and also who patient need healing very faster, like in elderly patient. Also perform rib fracture patient. If we think that non-operative will be give complication, and then why we try to perform operation of fixation. What happened in Indonesia? A lot of trauma cases, or especially thoracic trauma, coming to the hospital is delayed, because if happen in a remote area, the doctor in the skin just make a stabilization and they send to the trauma center. But especially is affecting the mortality and morbidity for the patient. For that, through as Asian Collaboration Trauma Indonesian chapter, I will socialize about rib fracture management to my friend in all over Indonesia. Thanks again to Professor Mark Moya, your good presentation. Also the committee to have chosen his topic is very useful for us in Indonesia. Is providing services for trauma patient, especially in general, and specific for thoracic trauma. Thank you. Stay safe, well, and safe. Thank you.
Thank you. Thank you, Dr. Hidayat, for your words of wisdom. And our next reactor is Dr. Jorge Conception. He is a chairman of Committee of Trauma in Philippines College of Surgeons. He is also chairman of the Committee on Quality Assurance and Patient Safety in Philippine College of Surgeons. He has been past president of Philippine Society for the Surgery of Trauma and Philippine Association of Training Officers in Surgery and Philippine Society of Emergency Care Physicians. Presently, he is working as a director of the Operating Room Management Team and vice chair of Department of Surgery in the Medical City. Dr. Jorge Concepcion will be commenting on the presentation by Dr. Mayur Narayan. Dr. Jorge, please.
Good morning, everyone. I'm Dr. Jorge Concepcion from the Philippines. So my task this morning is to comment on the presentation presented by Dr. Mayur Narayan. First of all, I would want to congratulate Dr. Narayan for a very informative presentation this morning. And I'm very happy to learn a new term, no? Jugaad, which means overcoming harsh, constantly improving an effective solution, which is very aptly correlated for surgeons, no, doing or managing cases with injury. I agree as well that necessity is the mother of all inventions, and MacGyver, as he used it, no, and as presented by Dr. Sagil, can be utilized as a verb or a noun. No? In his presentation, he used the word sheets, belts, bags, balloons, tubes, and machines to really help us out in improvisation on materials that we can utilize in managing our patients. No, sheets still being utilized in the management of pelvic fractures, the belts for hemorrhage controls. No, in the Philippines, still we are teaching this to improvise on things because we don't have that luxury of having all commercially available materials. No? To give you a story, one of our students in medical school was able to save a patient in the light train system when the said patient felt dizzy and fell into the rail track, and the incoming train created a traumatic amputation on the extremity of that patient. Presence of mind of the intern she asked the security guard at that time to remove his belt, and the intern utilized the belt to put in or place that as a tourniquet to the amputated to the proximal end of the amputated limb, and that saved the patient for the day. Balloons are utilized as well, utilizing Foley catheters and tubes as well. In the Philippines, we have to make sure as well that trauma care does not only happen in the emergency department or in the operating table. As an addition to the talk, I would still consider the MacGyvers utilizing sticks like bamboo sticks and poles as splints in the pre-hospital setting. Then blood are usually needs to be warmed. We don't have that much of commercially available blood warmers, especially in distant places in the archipelago. So one of our local surgeons developed a box. This box utilizes 25-watt bulb, and the plastic IV bottles are placed there in preparation for trauma cases. So meaning the IV bottles are placed there for them to be pre-warmed before being utilized to our trauma patients. And second is in terms of warming our patients to prevent hypothermia. To minimize the heat evaporation during surgery, some of us utilize garbage bags to wrap the extremities of our patients needing laparotomies to minimize heat exchange, or making sure that the patient is still warm during our surgeries. With that, I would want to thank the organizing committee for having me as a reactor in this activity this morning. Thank you very much.
Thank you, Dr. George. Thank you very much for sharing your MacGyver experience with us. Our next reactor is Dr. Guixi Zhang. He is the Executive Director of KHU SGS Trauma Center and Deputy Chairman of Shen Zhen Trauma Surgery Committee. He is a standing committee member of China Trauma Rescue and Treatment Association, and is member of Chinese Medical Association Committee on Multiple Trauma. He is also a renowned fellow of American College of Surgeons and fellow of American Association for the Surgery of Trauma. Dr. Guixi Zhang will be commenting upon the presentation by Professor Puyana on if Gulliver was a trauma surgeon. Dr. Guixi, please.
Okay, thank you very much, Dr. Dinesh. But here, first of all, I'd like to thank you everyone here and give me the opportunity to be involved, especially for the meeting committee. I'm Guixi Zhen from Shenzhen, from China, from Shenzhen, working in the University of Hong Kong, Shenzhen Hospital. This morning, Professor Carlos has given us a very excellent, it's a very outstanding lecture about the trauma, about especially for the mentorship. During the talk, Professor Carlos mentioned the first of all is the mentorship, and I'm really agree, and this is very important because for me, actually, I'm a young surgeon, and I also had an opportunity. I was awarded with American College of Surgeons International Scholarship in 2017, and actually I had the opportunity to visit USA in 2017, and I visited for very famous trauma centers in America. The first one is in Maryland Trauma Center, and the second one is Washington University, the Harborview Medical Center, and going to Professor Kumbula, San Diego, and then to Los Angeles, Professor Didi as well. So actually, during the program, I feel I had learned a lot of things from my traveling, my visiting. So Professor Carlos mentioned the mentorship. I think is very, very important, especially for the low and middle income countries, for the young students, give them opportunity to learn. And also Professor Carlos let us know actually the institute from Professor Carlos has been helping many other hospitals all over the world. I think many trauma surgeons visiting Professor Carlos and Professor Carlos institute and learn things, many things from there. So this is a part of the global health from Professor Carlos program. I think this is very, very important because it's continually to teaching, to helping many young students from all over the world to grow. This is very, very important. Need to be continuing. We hope we will have more chance. Professor Carlos can create more chance for the young students from low and middle countries, such as in Asian Pacific area. And the second thing Professor Carlos mentioned is the DSTC and the ATS course. These two courses is very important for trauma science all over the world. Actually, I have been working with the ACS China Hong Kong chapter. We introduced ATS program into mainland China in 2016. At the moment, Shen Zhen in my hospital, it was the only training center for mainland China. We had trained more than 200 doctors from mainland China for ATS. But yes, you know, in the past 1 to 2 years, because of COVID-19, we could not continue the course. But I think we will continue the course soon. For the DSTC, I attended the DSTC course in Hong Kong in 2014, something like that. At the moment in mainland China, we don't have the DSTC course. I'm not sure is there a chance for us to introduce the DS course into mainland China or not in the coming future. And the second thing is that actually the new version of the DSTC has been just translated into Chinese. Either from trauma group from Beijing, from Medical National Trauma Center in China, from Professor Jiang Baoguo and his team. And I think it is a very good and very important things as well, because the new book actually we are learning the new book at this moment as well. So I think today is a very important meeting. Actually, I have learned a lot of things from here, and I also want to share a little bit information. Is because in the past many years, in mainland China, we don't have ATS until 2016. Actually, China has developed a course called China Trauma Care Training (CTCT). Is propagating in mainland China. Is also to teach the doctors and nurses how to learn some skills and knowledge for trauma. And also in my hospital, actually, we have also create a damage control animal course in my hospital as well. Not like DSTC, but it's about damage control animal course on piece as well. So I want to share this information, and I hope we can have the chance to work together in the coming future, especially to learn more things from Professor Carlos. I hope in the soon future we can travel to each other and without the effect of the COVID-19. Thank you. Thank you very much, Professor Carlos. Thank you.
Thank you. You're welcome to come to Pittsburgh.
Oh, thank you. That's great.
Next reactor is Dr. Nam-Ryeol Kim. He is the president of the Korean Society of Acute Care Surgery and the director in the Division of Surgical Critical Care and Trauma Surgery at Korea University of Guro Hospital. He is director of Intensive Care Units in the Korea University Guro Hospital. He is attending surgeon in the Division of Surgical Critical Care and Trauma in the Department of Surgery, Korea University Medical Center, Guro Hospital, Seoul. He is a clinical professor of surgery, College of Medicine, Korea University. He is the board member of Medicine Sans Frontiers and director of the Korea Disaster Surgical Response Team in the Korean Surgical Society. Welcome, Dr. Nam-Ryeol. He will be reacting on the simulation training in critical care by Professor Mark Boyer. Dr. Nam, please.
Okay, thank you for introducing me. Sorry, introducing. I'm Nam-Ryeol Kim, working for Korea University Guru Hospital as a trauma surgeon and critical care medicine fields. Okay, I'm very honored and I'm very pleased to join this webinar for several times, and then especially today as a reactor. And then I'm very pleased to meet my old friend and the new friends in the world. I really enjoyed listening this Dr. Boyer's very short but intense and attractive lecture today from Dr. Boyer. And then thank you very much, and thank you again on behalf of the other audience. And also it was a good opportunity to think about the advantage, remind about advantage and disadvantage of simulation, several kinds of simulation in medical education, and its appropriate ways to applicate in the education. In particular, it was a very interesting and helpful lecture by showing an example of future development direction of simulation education, and with a very further advanced technology. Dr. Boyer showed some very interesting and some funny and examples. And then, in the generally speaking, in most of the paper articles, currently articles, various simulation seems to be used in many surgery and critical care, medicine and disaster, and also anatomy as well. Also, it was true in the field of trauma surgery as a kind of surgery. So in ATLS, ATOM, ASAT, SPSD, this kind of simulation training, in this educational course, the simulation training is a very, very important part of these courses. The field of application of augmented reality or virtual reality seems to require a lot of human imagination. Maybe common people, including me, cannot imagine this ultimate end of infinitive development. Just less than 10 years ago, we cannot imagine the iPhones used currently in the world. Anyway, however, as a contemporary trauma surgeon of me, please, I want some more explain how to this augmented reality technology can be added and merged in current trauma education like ATLS or ATOM like that. And in fact, this is I'm worried about this new technology to merging into the previous current educational course. This can, but this can be a common problem in simulation training, like other currently used. That means that if you augmented reality or VR, the lack of tactile sense seems to be getting us some problem to getting us competency especially in the surgical field to surgeon. Is there any additional? I wonder, is there any additional process and a technical process to solve this problem currently or future? And please tell about how to plan to apply this new way, new technology of teaching in terms of United States and as one of the leading country in trauma education. So and finally, in terms of cost, Dr. Boyer mentioned about the cost. Cost is a very important part to using the selection the way of selection the simulation part to education. So in terms of cost, this new technology will be cost higher than current method, but I guess I imagine for the long future time, the cost will be decreased. But nowadays, the cost is very high than the another technological simulation ways. So in contemporary period, what solution overcome this hurdle to you think? You, Dr. Boyers, think? And today's I'm very interested in the about simulation. So because I joined the developing the course of for residents of surgery in Korea in fields of critical care and traumatology. So I'm very happy to hear the Dr. Boyer's very good lecture today, and nice to meet him and then my friends. Thank you very much.